Hello there, is it Miss Smith?
It is.
Hello there, my name's Geordie Morell. I'm one of the doctors in clinic today. How are you doing?
Well, not very well really.
Oh dear, why is that?
Well, I've been having these pains and
Right.
it was in my stomach really to start with around the side. Now they've moved
Okay.
into my back more.
Right, okay.
Which is why I went to the doctor.
I see. And did your doctor give you any indication what he thought was going on?
No, I mean, I thought at first that it might be, an ulcer or something.
Okay.
He sent me here and I had some tests.
Okay.
And I must admit I did ask what the tests were for and
Right.
was absolutely horrified. It was my kidneys.
Yes. And have you had any experience of kidney problems before?
Yes, my
Right.
father's got
Right.
kidney problems.
Okay. What type of kidney problems does he have?
Oh, it's this cystic something.
Okay.
Polycystic fibrosis.
Right.
He's on hemodialysis.
I see.
And that has frightened me between the test and
Right.
I'm terrified today.
Okay. What is it that makes you so
Well,
worried?
in case I'm the same. It's just never occurred to me that it might be that. I don't live with my parents now,
Yes.
I've got my own flat,
Mhm.
but I've not talked about my symptoms because they've both got quite enough to think about with my dad, Possibly if I had, he might have given a warning shot.
Right. And from what you're telling me, it sounds like he suffers quite badly with this. Is that?
Yeah, he's been on two sorts of dialysis and he's now on hemodialysis. That's worse, isn't it?
Well, there are different types of dialysis. I wouldn't say
He's
one is worse.
peritoneal.
Peritoneal dialysis.
He was on first.
Okay. Fine. And how long has he been on treatment for?
Oh, years.
Okay.
20 years.
Right,
So,
okay.
Probably more than that.
Fine. And you're worried that you might have this?
Well, I am now, yeah.
Right, okay. Well, your GP did arrange a few tests, and probably the most important one that I'm going to talk about today is this ultrasound scan that you did of the kidneys, and it does show features of this adult polycystic kidney disease, I'm afraid.
I never knew it was hereditary. It's not chance, is it?
No.
It must be hereditary.
It does tend to run in families. It doesn't happen. It's not something that's automatically passed on from like in this case, father to daughter. I wouldn't have automatically assumed that you'd get it, but it does increase your chances of getting it.
This really, couldn't have come at a worse time.
I'm sorry. Why is that?
Well, I'm due to get married in the spring, and
right.
because I'm 30, we were going to start a family immediately, and they're going to be in line, aren't they?
Well, as I said, it's not necessarily. The genes that people pass on to their children are very much dependent on the genes of the other partner as well. And I say that there is a risk, but it's not a definite.
Is there anything I can do to protect them?
Well, what we can do is there's a lot of research being done into why people inherit this condition, and we can do the genetic testing on yourself and on your partner. Obviously, we'll want to we'll need to talk to him first about what he wants, but I can't go.
He might even run a mile.
I don't think that's gonna happen.
I mean, sort of getting back to me, how bad am I? Am I going to need dialysis?
Not at the moment, no. Your kidney tests,
So
other than
I might
the
have
scan,
a few years.
you may have. Many people have this condition all their lives and never need to go on dialysis. So it's not It's not a definite.
Right. Am I going to have any treatment now?
Well,
Is there anything that delays it getting to that stage?
In terms of what's happening with the kidneys, it's about, I'd be looking for all of the other reasons why people's kidneys might become impaired. So this condition is, relatively speaking, rare in terms of the people who end up on haemodialysis, like your father, or even peritoneal dialysis, as he was on before. The most likely problems are things like diabetes and high blood pressure. So I would be probably looking more at those things. Your kidneys are not normal in their structure because they've got these cysts, and that's where you're getting the pain from.
Right.
Because the cysts will either stretch and cause the kidney to become tender, or sometimes they can actually pop, and that causes some discomfort as well.
Right.
Now, in that respect, the treatment's going to be about pain relief and making sure that we are controlling the pain.
Yeah, I guess that was going to be my next question. I mean, what will you give me for pain relief? Am I all right taking medicines?
There are certain
or diets. Do these help or
there are
make
certain
things worse?
There are certain medicines that are certain painkillers which aren't so good for the kidney, and so I'd probably steer clear of those where possible. And those are the anti-inflammatory drugs like ibuprofen or diclofenac.
I've been taking ibuprofen for this back pain.
Right. And does it help?
This is only recent.
Right.
It does, yes. Well, at least it takes the edge off, makes it bearable.
Well, the class of drug that they're called, the ibuprofen are we refer them to as a sort of an acronym of NSAID, which means non-steroidal anti-inflammatory drug. So what would actually be a better tablet for the kidney is the steroid. So that would actually perhaps help with the pain, but not have the effect on the kidney. Don't worry about the tablets you've taken already.
Well, I've not been taking them for very long because I haven't had the back pain.
It takes a long time.
It was more stomach pain before that.
It takes a long time for them to cause damage to the kidney. So I wouldn't worry about those, but I would use those at most very sparingly. And we'd be much better with other painkillers, like paracetamol is a very underused tablet, and it's very safe and
doesn't do very much though, does it? I mean, it's all right for headaches,
but what it does do is it gives us a good baseline to work from, and then I find that it helps the other medications actually be a bit more effective.
Yeah.
So if you took paracetamol regularly and then an occasional tablet like codeine, it tends to be a bit stronger than the codeine would be on its own.
You mentioned steroids. I guess I'm going to be on tablets sort of for a long, long time. Is that not dangerous in itself?
I wouldn't want you to be on the steroids for a long, long time, because as you've said, there are problems with people taking steroids for a long time, and it can cause weight gain and thinning of the bones and thinning of the skin, and these are things that it takes a while to cause a problem with, but they're potential problems if people are on the steroids for a long time. What we tend to find with conditions like this adult polycystic kidney disease, it's been there for a long time. It's probably been there to some extent since you were born.
Yeah.
And it's just that we've come to problems. So we've managed, how old are you now? 20?
30.
So we've managed 30 years without a problem, and what we're probably experiencing now is a bit of a flare of the condition. So it might be that some steroids for a short course, by which I might mean a week or maybe two, or maybe shorter, and we might get the symptoms settled down. But we'll have to see.
Yeah.
we're going to be, you're now on our books, okay? Don't find that threatening, but that means we're going to be looking after you at regular intervals and checking in with you.
Day trips here.
Yes, not every day.
No.
We'll keep them down to as much, but it means that we're there for you. So when you leave here today and you think, oh, I meant to ask this, we're on the end of the phone, so you can go. And with kidney problems, it's a specialist area, and your GP will know a lot about it, but what we commonly find is GPs would prefer would sort of defer questions to us. So you may find that you see us more than you do your GP.
Right.
But that's fine. That's what we're here for.
Right, thank you very much.
But in terms of how things are going to pan out in the future, you may never need to go on dialysis or anything like that. And I think when you've had the chat with your partner, and we can help with that in any way.
And what about the question of transplant?
That's certainly there's we mentioned briefly two treatments for kidney failure. As I say, at the moment your kidneys are working perfectly.
Right.
When we get to that point of looking at kidneys failing, which I stress we might not do, there's broadly speaking 4 options. Number 1 is we do nothing, and we treat with medicines and manage the kidney failure as best we can.
Die.
Some people live for quite a long time without any treatment, but it's a choice, and it's something we work out together, and it's something that suits you in the end of the day. We mentioned hemodialysis, which is you know from looking after your father, he goes in regularly to the hospital and will have essentially his blood cleaned. So the blood is drawn through a machine, does the job of the kidney, and then gets the clean blood, in inverted commas, gets put back into him.
2 minutes.
Thank you. The peritoneal dialysis is does the job of the kidney, but in the stomach cavity. So we pour in a specially composed fluid, and that will allow the exchange. Basically, allows the blood to be cleaned through the lining of the gut.
Ooh,
I know that's. But I say we're not necessarily looking at any of them, and it is a choice for you. And then you mentioned transplant, and that's option number 4. Many people, we keep a monitor of their kidney function, and when it gets to a point where we're worried that the kidneys aren't working properly, then we start looking at the possibility of a transplant. And that's ideally comes from a living person. So what people often do at the early stages of when their kidneys are beginning to fail is talk to family members about the possibility of transplant, and we do tests, because in the same way that your genetics have passed from your father and you develop this illness, we want to check and see the genetics of the person who's giving you the kidney. Are they right for you? Will the kidney work properly? In rare cases, well, more commonly, but not as more commonly than we'd like, the kidney comes from someone who's died. So carrying that all-important donor card can, in some cases, mean that they donate a kidney.
And I suppose the flip side of this is it's better a bit earlier than later, because they won't put you on the list if you're too old, I think.
There's people. I'm not sure. I can't say for sure what the cut-off age is, but they certainly look at all the options till quite late on in life, because people are living longer and longer and are, maintaining a sort of relatively active lifestyle till late on. So we don't want anyone to miss out simply because they're a little bit old. And I think you're as old as you feel in some respects. But again, we're probably a good 30-40 years away from narrowing your options down. So there's all of those options, but we're well in the future there, and I think we're just at the beginning
Yeah.
And so you're going to
I
be
think
seeing.
the thing that worries me most is the children, you know. Have children, I think it's a big risk.
Can we stop it there just on the interest of time?
Sure.
Thank you. Thank you, Dr. Morell. So the lady was just about to ask you about the implications for her children. You touched on it earlier.
Yeah.
Could you expand on that then with this diagnosis that she's got, and she's clearly going to get married and she's planning a family?
Yes.
Just tell me, what the implications are and the risks, if you can.
Okay. Well, I believe that adult polycystic kidney disease is an autosomal recessive inheritance. So this would mean, in practical terms, if unless her partner was a carrier of the disease, it's very unlikely that her children would develop it. The fact that she's developed it and her father has it may suggest that if we looked at the family tree and went through some sort of proper genetic counselling, we may see that there are several members of the family with the condition, and therefore it's much more likely that she was going to inherit it than, because it's possible that her partner has it, but we'd obviously need to look at his family tree, and as I said, there's a number of genes have been identified as culprits in inheritance, and I did mention that we could screen her for what genes she was carrying, and we could also screen her partner, but obviously that's going to involve, she was worried about telling him the diagnosis and the potential that her children will develop it. I suppose I could have done more to allay her fears, because she's obviously looking at her father having it and then her developing it, and therefore it's, in her mind, it may be a foregone conclusion that all of her children would develop it.
Yeah,
So
I think you did. You did say that it's a risk, but it's not. You did say, I think, that it's not a foregone conclusion.
Yeah.
So who would you involve in those type of discussions? Because this is the renal clinic, isn't it?
Yeah.
Perhaps a renal SHO.
Yeah.
Who else might be involved in this type of decision making and testing?
There's usually within my renal unit there would be a research department and who would have links with molecular genetics, and I think they would be sort of the principal people. It may be that all of this can be done just on a sort of a bespoke service for them, but it's quite likely that there's a screening program that's part of an ongoing clinical research trial. Or
so there should be some experts who would look into it.
Yes,
it's not something that you send just a test off and
no.
have a chat.
Yeah.
Okay. Steroids. You mentioned steroids. Tell me about the use of steroids in adult polycystic kidneys, because you did mention it.
Yeah, I'm not entirely familiar with exactly how they'd be delivered. I think the course of the disease is there would be flares, so there would be periods of inflammation, which can be controlled with treatment with steroids, and can sort of reduce some of the autoimmune response, but also in much the same way that liver capsule pain is treated with steroids. Similarly, the cysts bulging within the renal capsule, steroids will actually reduce the pain and inflammation there.
So these are generally given in bursts.
So that's my understanding, but I guess because the only other reason for giving it would be if the renal function was impaired, and at the moment my information is that the renal tests are normal, so we wouldn't be looking for preservation of renal function at this stage. We're looking for symptom control.
Okay. Good. And you mentioned a few of the complications. Clearly she was very interested in dialysis and transplants, because that's her own experience of it. You mentioned a few other complications. Do you want to just explore those and tell me what the complications are? So
at this early stage, I'd expect her to be getting some. She's getting some pain from the cysts themselves, which can enlarge and rupture, and that can cause some pain and can cause hematuria. we often find people with polycystic kidney disease will also have cysts in other organs. So you can have polycystic liver or polycystic ovaries, and that would be something else. I didn't want to muddy the waters in terms of her. So not only would she be at risk of her children developing it, but she may be infertile as well, or have problems with conception. So I steered away from that on purpose. Not all patients will develop renal failure, but that's a possibility, and it's something that we're going to be monitoring closely, and that's going to be the prime focus of her ongoing follow-up. Commonly, occasionally, the polycystic kidneys can become so large that they actually need to be removed for just because they occupy too much of the abdominal cavity and compress on other organs. And so they can be removed even when they are functioning reasonably well. Sometimes you need to have one or both kidneys actually removed.
And you mentioned diabetes or hypertension.
I mentioned diabetes and hypertension as things that were more likely as more common causes for renal failure.
Oh, sorry.
So
that's why that was mentioned.
Yeah. So I think these are things that I would be screening for.
Yes.
And then we also moved on to touch briefly on analgesic nephropathy.
Yes, sorry. Yeah. I mean, is there an association between hypertension and adult polycystic kidneys?
It can be. You can get secondary hypertension as a result of the renal disease. So.
Good. Was anybody else affected in the family? You certainly mentioned the dad.
I didn't ask about the rest of the family, and I think that's something that would be useful to come out in genetic counselling.
Yeah, so that would all come out then.
Yeah.
Okay, good. And a slightly different point, and just a discussion point, shaking hands with the patient in the communication, possibly the history. Do you shake hands with everybody? Do you think it's a good thing? Do you think everybody should shake hands?
I find that the vast majority of people, the human touch is appreciated, and I think you have to judge each setting on its own merits. I have been told off on occasion by usually the husband of an Asian lady, and that it's culturally inappropriate to shake hands. So I think I do exercise some caution. But on the whole, I would.
You're a handshaker, which is fine, isn't it? Yeah, and I think it depends what you do, isn't it? And if it's natural for you, but just be aware, as you say, of cultural differences.
Yes.
Excellent. I think my feedback for you is that certainly running through the scenario, again, it's very important, isn't it, to get what they know, what the patient or the relatives know about the condition that you're about to talk about, and not just has a family member got it, but to explore, how it's affected that family member. And I think you did that excellently. And I think you certainly, again, not used any jargon terms at all. Everything's in layman's terms. And, I think the lady left, although she was terrified at the start, I think she left reassured that actually she's had this condition for 30 years and she's got a bit of pain, but her kidneys are fine. And although things can happen, it doesn't necessarily mean, she is going to go on dialysis like her father. So I think you reassured her and you found out why she was terrified, and then you reassured her very nicely. Good, well done.
Thank you.